Hospital. I absolutely love cardiology. I've done it since 1979, before some of you were born. And we're having 3 guest speakers. We're having Dr. Mark Russo, is a Naples nephrologist, and he'll be giving a secondary hypertension lecture. Dr. Rajesh Singh, who is a vascular surgeon, he's going to do vascular medicine surgery lecture. And Dr. Javier, whose brother was a baseball player from the Dominican Republic, really famous, so don't mention that because he gets perturbed because he's just a cardiologist and the family doesn't think that's much of an accomplishment compared to his brother, and his father played baseball too, Julio and Javier. So anyways, so he's going to do ischemic heart disease. He's an interventional cardiologist in Naples, and I'm going to do the rest of the lectures, and it goes all the way till November. So we spread them out like that so you could absorb it, because a large part of the PANS is a lot of cardiology questions. I know because I've taken the PAN read many, many times because all the cycles. And I'm going to take it again in December. And I remember the questions that they asked in cardiology. So I can give you lots of clues through this. And in fact, at one point I'm going to give you PANS questions, PANS type questions, and I can guarantee you there's at least a dozen questions that every single time I've taken it, they're on there. So those will be some freebies for you. There's a couple of them on this lecture, and this lecture is based on the PANS. You could talk about congenital heart disease for the entire year. We could just do congenital heart disease. There are so many things to do. So we're not going to do the prenatal circulation, embryology, or anything like that. We're just going to go over the diagnoses that are listed on the PANS blueprint. And the course is going to pretty much follow that as well. So when I do valvular heart disease, we're just going to talk about the valvular lesions that are on the PANS. So I do the basic description, then the signs and symptoms, the physical examination, the treatment, the prognosis, and I like to throw in the follow-up for a lot of things, what it should be, even though that's not necessarily a PANS question, but you need to know that it's going to practice. So I don't really have time today to go through. I've got it figured out, the order of the lectures and what's going to be on the first test. You can see when the first test is. I think there's 7 classes. One of them's going to be on Cardio Jeopardy. The class right before is, or might be one before, we'll see. But then next time I'll give you, or I'll post it in the announcements with the breakdown of the classes is to help you look ahead. The book's helpful. The test questions are going to come from the PowerPoint slides, and we're going to have one lecture on cardiac pharmacology, all the drugs we use. Even though you have a lecture like that in your pharmacology course, I'm still going to give you my viewpoint on it. I'll show you the book I bought of cardiology. When the last trip I took went to the Intensive Review of Cardiology, the 16th annual one at Cleveland Clinic a couple of weeks ago, and I bought a cardiac drug book. But I don't recommend you buy these because cardiology, more than any other specialty, the drugs change so fast. There's so many new ones that it's going to be outdated. So even that book's a little bit. It was written 2 years ago, and some things have changed since then. But I'll base the talk on that because the PANS is always a couple years behind too, the latest recommendations. Okay. So anyways, we do congenital heart disease, and these are our objectives. These are the disorders it covers: atrial septal defect, VSD, aortic valve stenosis, pulmonic valve stenosis, coarctation of the aorta, patent, ductus arteriosus, and tetralogy of Fallot. And then these are starred because these have been seen. There are several things that are seen in Down syndrome, the starred one, so that's what that's there for. Because you may see some mention of that. But we're not going to worry about the percentages of each one. I'm not really big on numbers and percentages because you can always find a different reference that'll say that it's different, depending on what book you use. So I have very, very few numbers in here. So there's the content blueprint. I divided into holes in the heart, vascular issues, valve problems, and there's one complex cyanotic disorder that they mentioned. So maybe that makes it a little simpler for you to see two kinds of holes at the top of the bottom, two vessels, the aorta, or a connection between the pulmonary artery and the aorta, three valves, the aortic, the mitral, and the pulmonic. And this has four components, and every single time there's been a question on tetralogy of below. So you need to memorize the four components, which will be on one of these slides. Okay, very small percentage, 0.8. Not even 10% of all live births are complicated by congenital cardiac. But they're doing really well. Of course, 100 years ago, they all died. But now, the procedures are becoming more and more vascular procedures rather than open heart surgery. Being able to do things through catheters and put shunts in and occluders for holes so babies don't have to be operated on. It's getting safer, shorter procedures, less anesthesia. So why does congenital heart disease happen? Most of the time, probably 90% of the time, we don't know. It just occurs sporadically. There's one risk factor that seems to be common, and that would be maternal diabetes type 1. There's many more congenital defects for those ones. Environmental factors, such as things maybe like fetal alcohol syndrome, could cause it. Mother's drug use. There's and you can't do studies on that. When you have like a group of people, you give them drugs and the others you don't, and you say you get congenital. It doesn't work that way. So it's anecdotal and that kind of thing. All right. So some congenital defects, the kids do fine, and you don't operate on them. You just watch them and see how they're doing. And other ones you have to operate within the first year. Especially things like cyanotic heart disease, which is the only one that we're going to discuss, is cyanotic tetralogy of below. And that one, if you don't operate on them within the first year, they have a dire outlook. But many of them you can wait even to adulthood, for example, of hole in the heart. Even a ventricular septal defect that's small enough. I've had 18-year-olds come see me in clinic that just wanted a cosmetic repair because their chest vibrated and they were embarrassed. But they didn't need it because they were okay. So it depends on what it is and what kind of gradient is caused by it. The tests that you need to know about, I don't know how many of you know what all of these things are. Is there anybody here that knows every single one of those? They've heard of it, they know what it is? Anybody here? Sort of good. Yeah. Alex, Bob, you've heard of all of those tests. There are some people that don't know what those things are. Anybody that doesn't know what every one of those things is?
Yeah.
Okay, then I should probably just briefly explain it. I decided not to put a bunch of pictures on there and a bunch of videos showing these procedures and things like that because it would take a long time. But just go on YouTube, you want to see what a magnetic resonance imaging is. You can find all this stuff on the computer. So you just do that on your own time what these things are. Electrocardiogram, we're going to do a whole course on that. That's going to be the sticky pads on the chest attached by the wires to the EKG machine, which is just a computer, and you're going to become experts in EKG. So that's one test you can use, even on kids. You can do that. A transthoracic echocardiogram is the most important test that's on here. You can diagnose everything on that. You can measure. It's sound waves. It's bouncing off a transducer that you put some gel on the end of it. Anyone ever have it for a baby or do it in women? It's exactly the same test. You put on the belly, you do it for the heart, and you bounce the sound waves off. So it makes an image, and it also is with Doppler, the same thing they use for the weather. They call that Doppler too. So you get the movement, and you get the gradients, and you get the flow of blood through the heart. You get the measurements of the valves and the chamber sizes. So you get a ton of information. It's very cheap, and you need it for every kind of heart problem. You need an echocardiogram. A transesophageal, and you can do it too in a child without worrying about anesthetizing them. If they move, then you just start over and move it again. A transthoracic or transesophageal echocardiogram, TEE, is they have to swallow the transducer. So in the beginning, when the fellows started doing this in the 70s, people gagged horrible. It was not a pleasant thing to watch. So they anesthetize them. They usually do it in an endoscopy suite where you would have a gastroesophageal duodenoscopy or colonoscopy, that kind of thing, where people have to be asleep. So We put them asleep with IV anesthesia, and we don't even have to numb up their throat then, and they just push that right down, the unconscious person, and they're just asleep for a very short time. And you get that transducer is right next to the heart, so it's only the thickness of the esophagus away from the heart, so you get even better pictures if you have things like an infection in the heart, and you want to look for growths on the valves. You can see them, where you might not see them on the transthoracic. If people are large or have large AP diameter, sometimes or large breasts in the waist, sometimes you get poor pictures with a transthoracic echocardiogram. Magnetic resonance imaging is, it's a huge magnet, and it shakes your molecules a little bit in space so that they can make an image, and that's also not an invasive test unless you do contrast with it, and it takes a long time to do it. Anybody ever had an MRI? You know what that is? Okay. I'll try to claustrophobia too. Really gives a lot of good information, and it is good for soft tissue, so you can use it for the heart. So we do use that. Computerized tomography's been around a long time. CAT scans is, and now there's spiral CTs where the technology has changed, where you can get more information with less radiation, but it is a whole lot of X-ray. So we use that. We can even look at things as small as pulmonary arteries when we do ablations on the heart, to look for scar tissue in the pulmonary arteries where those ablations take place, to follow up with them. So CT is very helpful. And cardiac catheterization is used very frequently for diagnosis of ischemic heart disease and for placement of stents in heart arteries. And that's put through the femoral artery. And you can also do a right heart catheterization that we put through the femoral vein to get to the right side of the heart. Remember your anatomy, where the femoral vein goes to? What's its next stop? Femoral vein, then where? Okay, and then the next, the IVC, and then where does IVC go? And then you can get from the right atrium to the right ventricle, and you can get biopsies, you can put pacemaker wires in, and you can do right heart catheterization and get pulmonary artery readings, that sort of thing. So left heart catheterization is through the femoral artery to go to the origin of the coronary arteries, which come, where are the coronary arteries? Where are they in the heart? Where do they start, the origin? The aortic valve. Yeah, the aortic valve. So that goes retrograde up to the aorta, over the arch, to the aortic valve, and to the orifice of the coronary artery to inject dye to get a video of the coronary arteries. That's a heart catheterization, or an angiogram is the product that you get. Okay, so that's all the tests. Not the lab tests, of course. We're just talking about imaging for congenital heart disease, because congenital heart disease is a surgical condition for the most part, not a medical condition. So you need imaging in order to be able to do treatment, which is surgery or occluders, that kind of thing. So that's why we're not talking about lab tests here. The very first defect we're going to talk about is atrial septal defect, and it has another word. Endocardial cushion defect is the same name. That's this here. This is the cushion. Goes all the way between the heart. Of course, it's thicker between the interventricular septum than it is the interatrial septum. So we're all born with a hole in our heart. It's called a foramen ovale, and it's to mix the blood before you're born. There's a little flap that closes over the foramen ovale, and sometimes that flap's movable, so it sort of transit open. Some people have a little tiny hole that's left, and it doesn't cause any symptoms for the most part unless it's a large atrial septal defect and gradients are involved. So you're mixing venous and arterial blood, oxygenated blood and non-oxygenated blood. Where's the non-oxygenated blood? Where's that in the heart? On the right side. From the IVC into the right atrium. And the right ventricle to go out, which structure? The pulmonary artery. Goes out the pulmonary artery, picks up the oxygen, and the oxygen returns to the heart where? In the left atrium. And then left ventricle, and then the left ventricular outflow tract is the aorta. The right ventricular outflow tract is the pulmonary artery. So it consists of the ventricle, and then as it goes out of the heart is each of the outflow tracts, like that. Okay. So apparently there's some association of fetal alcohol syndrome and atrial septal defect. That's just some of the bases is the word you use for description of people that look different because they have some kind of congenital thing. There's some particular things with fetal alcohol syndrome. And that's congenital because the damage happens to a lot of babies in utero from that toxin. Now, there's atrial septal defect. I mentioned patent foramen ovale, but the majority of them actually isn't this more benign kind of patent foramen ovale. It's ostium secundum it just means it involves the fossa ovalis. Now, fossa ovalis means oval fossa. So it's just the shape of it. It's not perfectly round. It's oval like that. And then the foramen ovale means, foramen just means open. So it's a variation of ostium secundum. Okay. Now so this is the worst, ostium primum. Then ostium secundum would be a more severe, that would be a true atrial septal defect. Whereas a patent foramen ovale, even though patent means open hole, a foramen ovale is much smaller than if you call it an ostium secundum. Does that make sense? So we all have a foramen ovale, but it closes. But if you have a persistent open or that it's larger, then you would call it an ostium secundum, and that's the majority of the atrial septal defects. Not this. The majority of these are not a defect. The majority of these close. So if it's a true defect and a problem, it's called ostium secundum. Now, ostium primum it involves not just the atrial septum, it involves an atrioventricular septal defect, meaning it extends, and when you start going down the interventricular, or the cushion of the heart, what happens when you move below the atrium? What's there?
Septum.
The septum?
Ventricular septum.
Yeah, and what's attached to the ventricular septum? Valves. So it could involve, we're not talking about moving up towards the aorta, we're talking about moving down towards the mitral valve, the tricuspid valve. They're both attached to the septum, but on different sides. So you can have incompetent valves if the hole's big enough, then the valve isn't going to work correctly, right? So that would be bad if you have a hole that extends all the way from the top of the heart to the bottom of the heart. So that's ostium primum. Much rarer, but much more serious than ostium secundum. So this is just an ASD. This is fixable, has a much better prognosis. This is usually involved with more complex congenital heart disease that we're not going to talk about.
No.
There's many kinds. Right, now we're just going to stop there because they said you have to know about ASD for the PANTS. I don't know that they differentiate into secundum and primum and PFO. However, I wanted you to know the difference, that some are not as much of a problem as others. Because one of them even makes a murmur, and there's a question on ASD, which we'll get to in a few slides, that you've got to memorize now and understand the physiology so you don't forget it and mix it up with anything else. So that's why I wanted you to know the difference, which one is serious and which one is not, so you'll understand why one makes particular kind of heart sounds that you have to remember for the PANTS. So they have decided that you need to know what ASD is. Okay, so there's a picture of what I was just talking about. So ostium primum, the worst kind of all, goes all the way down in here, and it could affect the tricuspid valve or the mitral valve. They make those pictures flat and 2D, and they're not. The heart's rotated. What's in the front? Left ventricle or right ventricle?
Right.
So right. So, but they always show the heart cut in half and laid out flat. So they always rotate it. So the valves, even though it looks like the valves are away from there, they're really not. It's all the four valves are all just crunched up by each other. Are we good so far? You all following me? I'm not going too fast? Yes?
So does everyone right now have a PFO?
I don't know, unless you had an
But it closes
echocardiogram.
up,
It could be asymptomatic.
Does it close up like a week after you're born, or like you said that everybody's?
It's supposed to close up right away when the baby takes its first breath,
First
and
breath,
that
right.
the little flap shuts over it. I don't know how long it takes for it to grow, but it, in essence, there's a flap of tissue over there. People can have an aneurysm through it where a little flap of tissue bulges. They see that on echo sometimes, and that's because that's a weak spot in the center where the tissue's centered, because there used to be a hole there. Sometimes you'll see aneurysmal bulging. You'll see that on the echocardiogram report. Which you don't have to know how to do echocardiograms, but you have to know how to read the report when it all is. Which you will when you're done with this module. I'll bring some real ones in from our office. We do echoes and nuclear stress testing. Dr. Tolano's office, who's one of the preceptors for cardiology. So if you want to do that as an elective next year, you can. They just hired one of the PAs that graduated. George Beaverson, I worked there for Dr. Tolano. I'm just there one day, he needs more help than that. And we have a nurse practitioner too, and an electrophysiologist and then Dr. Rao, who also works with you, he's great. And Dr. Tolano, and Dr. Bailey, and Dr. Fox. Good, really good practice. With a lot of patients. Okay. So anyways, we talked about the purpose of that, you need a hole in your heart before you're born, because how are you gonna get your oxygenated blood from one side of the heart to the other and out the heart? Because it doesn't go to your lungs. So mama gives you your oxygen, gets into your heart, and then you send it out. So there's the answer to your question. It could take a few years for it to close completely. It's not a problem for a child to have a patent foramen ovale because there's not enough mixing of the blood to make the person cyanotic, and because the pressures are normal inside the heart, and because they don't usually have strokes or clots. So we'll learn shortly why an open hole could be a cause of a stroke. But not in a baby. They don't have arteriosclerosis, and they don't have thrombotic conditions or take drugs or have stasis or any of that kind of stuff. So most people don't know unless you happen to have an echocardiogram that you have a hole in your heart, because it doesn't make a murmur. It doesn't make a sound. Why would a hole make a sound? We're going to do a lecture on heart sounds, and I'm going to do the lab with you, and Dr. Newsom has you from 10 until 5, I think, next Thursday. We got a heart sounds lab, so I'm going to be in there with you. We'll do a whole bunch of fun stuff then, and you'll understand better what makes heart sound. So if you have a hole and it's big enough that you need to close it, they can actually put an occluder here. This came, where do you think this originated? Where did they put this? Right, good, femoral vein. Because we want to go to the venous side, and then we go across there, and with that thing there, and plug up the hole. So you only need to do that if the hole is large enough to make a gradient and cause a problem. It could take years to do that. So there it is in place. And again, you can watch whole videos of them putting these different things in, whatever you're interested in seeing. It would take a long time if we did all that. Now, I did want to tell you about some pressures here. So I'm telling you about some numbers just so you'll understand what's going on. What do you think, what is your pressure in your heart when the blood's coming out your aorta? Just systolic. We'll just talk about systolic pressure. On the average, how many millimeters of mercury is that? 100, yeah, or more, depending what you're, well, let's just start with 100. So after your blood goes all the way through your arterial tree, goes down to your toes, comes all the way back up via valves, and where does it land? IVC, and then, okay, what's the pressure by the time it gets to your right atrium? Like nothing, practically. It's 2 to 10 millimeters of mercury. So it went from 100 down to 10 at the most. You see why? It lost its oomph. It went all the way down to your toes, and the only way it got back up was the valves closing. There's no more pressure. You got one squeeze. You got your one squeeze from your heartbeat. Out your left ventricle squeezing, built up 100 millimeters of pressure out your aorta, and that's it until the next heartbeat. So by the time someone diastole here before, that's the pressure in the left atrium, the right atrium. It's a little bit higher in the left atrium. I'll explain why. Is because when the right ventricle contracts, because there's nothing between the aortic valve, between the left ventricle and all the way down to the toes until it returns. There's no other pumping. When it comes in the right atrium, it comes back in the left atrium. And then you have, when you have the right ventricle squeeze, it just squeezes the lungs, correct? A very short distance. So what is the pulmonary pressure? How much pressure do you need to get the blood to your lungs? Could be 15, 20, and if it's high, it's maybe 30 millimeters of mercury. You don't need 100 millimeters of mercury to get it to go this far, right? Okay, so you've got that pressure, so it goes out to the lungs and returns where? This oxygenated blood. To the left atrium. So, is the left atrial pressure higher than the right atrial? A little bit, because you got that squeeze, you just got that squeeze from the right ventricle, and it sent it out the pulmonary artery, correct? The lungs picked up oxygen, and it went all the way through the lungs, and then returned into the 4 pulmonary veins have oxygenated blood in it. Now, you see why the left atrial pressure is a little bit higher? It just had to go to the lungs and back into the left atrium, and it just had that squeeze, that 30 millimeters of pressure squeeze from the RV, and lost some along the way, but it might be 10 about when it's left. And then over here, in our right atrium, it had to go all the way from my toes, and it had that squeeze a long time ago on my left ventricle. Even though it was 100 millimeters of mercury, it had miles of blood vessels, of arteries, arterioles, capillaries, and then venules and veins, until it got up to the veins and venules, until it got to back to the heart. Now, the reason I make a big deal about this is because I want you to understand the direction of the blood, why it goes which way it goes, because that can give you a stroke. So you need to understand. So if you have a hole in the atrium, normally that blood does not communicate. So if you have this hole in your atrium, which way is the blood going to go to that hole? From higher to lower, correct? The higher pressure is going to push to where the lower pressure is. Low pressure can't push against this wall of high pressure. It's going to go backwards away from that pressure. So which way is the blood going to go? Yep. Left or right, because it's higher pressure. So you understand why the pressure is higher in the left. Okay. Gotcha. So the usual shunting is left to right to a hole, to the defect. And things can happen and change in the opposite direction. Now, why do you think it would be bad to have shunting going right to left? What is the left side of the heart? Or what kind of circulation? Systemic circulation. And what's the first stop of the left ventricle going out the aorta? What's your first stop? Yeah. Now, tell them.
Your brain.
Your brain. So you think that having blood change its direction, going right to left and out your brain, might take some unwanted passengers? What could possibly go through your heart that you don't want to go up to your brain? Clots. Correct. That is called a paradoxical embolism. Okay? Because it came from your heart, from the venous circulation. That's how a venous circulation can get from the right side to the left side, to the systemic circulation, and cause a stroke through a patent foramen ovale or an AFB. So an adult might just have a patent foramen ovale and have a condition that gave him a clot. Babies don't usually get clots unless you're manipulating in their heart, doing catheterizations, putting catheters inside the heart can make clots form on catheters. Adults get clots from what behavior is the main behavior that causes clots? Sedentary is one, right? You can get clots in your legs. What's another behavior that we absolutely hate that ruins? Smoking is thrombogenic. Smokers get clots. and they go through there. Drugs can do it. Being on, having a regular rhythm like atrial fibrillation and making clots inside of your heart can get sent from one side to the other and into the systemic circulation too. So the clots can be formed in your legs, in the venous system, they can be formed inside the heart in the upper chambers and go out the systemic circulation. They can be from toxins you put in your body, like smoking, or how about birth control pills? Hormones can make you more susceptible to making clots, so there's lots of ways you can get it. Obesity causes a thrombotic state, lots of things. Okay, now people that have other risks, that have an ASD, let's say they have other diseases. If you have we're going to talk about pulmonic stenosis in a few minutes. If you have a blocked pulmonic valve, or you have a pulmonary embolism, probably one of the most important diagnoses you need to learn about. I did the first site visits, and they had PEs. They even had a 39-year-old die from a PE. Yeah, that's it.
Shunting, if you shunt like if that was an air and you still have the clot, you just have a pulmonary embolism instead of stroke.
Right, because the pulmonary embolism is to what part of the circulation? It's to the lungs, so it's to the right side of the circulation, the lung circulation rather than the brain circulation. So what the point I'm trying to make is that you have more chances of having clots of the systemic circulation if you have conditions that raise the pressure in the right side of the heart and change the gradient from left to right, or right to left. So if you have right-sided disease in your body, i.e. things that lung conditions or anything that make lung pressure higher. So, right, you already have a problem if you have a pulmonary embolism, but anything that makes right-sided pressure higher is going to change the flow of the blood from left to right to left. Emphysema, COPD, sleep apnea, even temporarily coughing and Valsalva maneuver. Now, everyone know what Valsalva is? Bearing down, holding your breath, bearing down as hard as you can, that's Valsalva maneuver, okay? And that temporarily raises your pulmonary pressures when you're holding your breath and bearing down, and that can temporarily possibly change the gradient, okay? So are we clear on, does everybody feel confident that they could explain paradoxical embolism? Like you tell your neighbor, you explain the circulation to the heart and why it changes and how it becomes systemic? Okay, because I expect you to understand that, and if I didn't explain it clearly, you need to tell me right now, and I will be glad to explain it again.
Okay.
Yeah, can we explain it again?
So when we're talking about the embolus that travels to the brain, we're talking still about left to right movement of the blood in the heart through.
No, right to left. Okay.
And then,
Pulmonary embolism is just an example. If you have that in the past, or you have a chronic condition, any kind of lung condition, you can increase the pressures on the right side of the heart and make the blood flow across an opening into the left side. That's not, I'm sorry if that confused you.
but normally the pressures are greater in the left side.
Correct. Normally the pressure is greater in the left side. That's what I want to make sure that you understand how to explain there, because we're talking about, even though we go all the way down to the feet, we started out with 100 millimeters of mercury. Okay, so you're gonna have higher. But when you return and you go out the aorta and you come up the venous system, you're coming into the right side, so you lose all that. And whereas the other side, you get the improperly RV contraction. Okay, we good on that? All right. Other things happen when you have atrial septal defect. Anytime you change the anatomy of the heart, so the right atrium might get larger because it's getting more blood pushed over to them than there normally was in the right atrium. It's going left to right. So whenever you stretch the atrium, you can cause atrial fibrillation, which is an irregular heartbeat caused by a change in the anatomy of the atrium. So aging changes the size of the atria. Hypertension changes it. A shunt definitely would change it. COPD would change it. So we talked all about that, what paradoxical embolism is. We had all this. children don't really have that much problem with the shunting. Children actually have higher right-sided pressures when they're born, and the left side becomes predominant in the baby because what is a baby's main job when they're born? What do they do? Breathe. Breathing is their main job. They breathe, and they eat, and they sleep. Do they walk, crawl around? No, so what do they need their left ventricle for? They don't need it so much. When they start using their skeletal muscles and they need to send oxygen to their whole body. So their job is growing, and so for growing you need oxygen and food, right? So the right ventricle is predominant in a baby, so babies don't get too much problem with paradoxical embolism. Or the shunt is not even a big deal because the right ventricle is strong. They start breathing right away. Babies have respiratory arrest. Adults have cardiac arrest, okay? The adults over time develop disease in the left side of the heart, in the muscle, and babies, if they have a problem with drowning or choking or aspiration, they have a tiny trachea, their big issue is breathing. So that's what, if a baby gets sick and has an emergency, they'll have a respiratory arrest, not a cardiac arrest. They don't have coronary artery disease, don't get heart attacks, they get problems with their breathing. Okay, so anyways, if they go long enough that they have shunting through there, eventually they'll have these symptoms, fatigue and dyspnea, because as the blood goes from the left to the right side, they'll start to put a strain on the right side of the heart. Not only just the right atrium, that'll transmit to the right ventricle, and that transmits to the pulmonary artery. As you get higher pressures in the pulmonary system, they get short of breath. And the arrhythmias occur from the stretching of the heart. And a pathognomonic symptom, if someone were to have a mini stroke, my husband had a TIA, that's what you call a mini stroke, and they put him in the hospital, and it was because he's a smoker, and he had erythrocytosis as well. You understand why you would get erythrocytosis if you're a smoker? You make more red cells because the hemoglobin is taken up by the carbon monoxide on the blood cells, and you're not carrying as much oxygen, so you make more red cells to try and compensate. Well, people like that, they make clots easily, so the first thing you want to do is see if he had a hole in his heart. So you do an echocardiogram to see if he could have had a paradoxical embolism. If a clot could have gone to his brain through that hole from the right side to the left side of the circulation, okay? So that's why you want to understand this, because if you got a PANS question and they describe a paradoxical embolism, they said the person was found to have a PFO or an ASD, they would want to know, is this correct? You know, is this how it happened, that kind of thing. But that doesn't usually happen to children because kids don't smoke. And like I said, the right ventricle is stronger, and they're able to resist that extra flow over there for a while, and it takes years till we get bad enough to do that. Okay, here's the PANS question. I want you guys to all understand this. A little more physiology here. They asked this every time I took it. And I took the PANS twice, and then the PANS, because I let it lapse when I went to nursing school. And I had to take the exam again. And it was there, and that was a long time ago, and every single candidate asked this question. The S2 is widely split. That's the heart sound you hear. Okay, so now you're going to say, well, I don't remember what S1 and S2 is. What's S1 caused by? The closure of what valves? The AV valves, which are mitral and tricuspid. Okay, think of it this way. The blood has to go to the center of the heart from the upper chamber to the lower chamber before it gets ejected out of the heart to the body, to the lungs of the body, right? So S1 is the closure of the mitral and the tricuspid valve. So you got to go through the heart, and it's controversial what makes heart sounds. We're going to talk about that a whole lot more, but you have to know this to understand why it's widely split. So when it goes through those heart valves, some people say it's the blood reverberating in the chambers. When the leaflets close and the blood, like boom on here, makes that sound. I don't know if it's actually the valve, nobody really knows. So anyways, so that's how you remember what the first heart sound is. because it has to go through the heart, right, before it gets ejected from the heart. So it's collected in the atria, down to the ventricles, the AV valves closed. So what's S2? Closure of which valves? The aortic and the pulmonic valves, S2. Okay, so it's S2, which is widely split and fixed, meaning it sounds like, depending on where you put your stethoscope, either at the base or the apex, where are you going to hear the second heart sound better, at the base or the apex? The base. You're going to hear S with the base, because aren't the aortic and pulmonic valves above the tricuspid and the mitral valves? The four were all close together there. Okay, so if you listen to bass, S1 and S2 sound like S1 is softer because it's further away. S1 is, so S2 it'll be bump, 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 bump. First sound I made is S1, and the second sound I made is the S2, and it's louder. And if it's split, it's bump, 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 bump. So it's split and they're the same intensity, and it stays split. It doesn't vary with respiration. And the reason it doesn't vary with respiration is because you now have more blood in what chamber because of the shunt?
In the right.
Okay. In the right atrium, where does that blood go?
To the right ventricle.
Right atrium to where?
Right ventricle.
Then where's it go?
To the lung. To the lung.
Which valve? The pulmonary, the pulmonic valve. Okay. If you have more blood to eject, I mean, it's the same blood that goes to the whole heart, so we're talking about the same volume that's doing its thing. So if you have the same amount of blood, if you've got more on the right side, because some left the left atrium and put a little bit higher volume onto the right side, it's going to take long for the valves to close because they got to close over this, you know, this blood has to come out. Okay, waiting, blood go out, blood go out, blood get out of the pulmonary artery, close. Takes longer. So the pulmonic component of S2 consists of A2 and P2. The aortic sound, second heart sound, the pulmonic, second heart sound. The P2 is delayed because it's waiting for that extra blood to get out before it closes. So aortic closes first, then the pulmonic valve closes. So we have a fixed split. It doesn't vary as you take a deep breath and change the venous return. When you breathe in, normally when you breathe in, your diaphragm drops and you have more blood rushing, you've got negative pressure in your chest, and more blood drops down from the superior and inferior vena cava into the heart. And that'll make your heart sound split. But that's physiologic because the next heartbeat it won't do that. So when you're breathe in, it's split, bump, 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 and then when you breathe out, bump, 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 bump. That's physiologic, that's normal. But the thing that you have to remember the camp is you can have a fixed split of the S2. So if you hear that in a little baby, it might be from this, or a child that still has an ASD that's not been repaired. If they have a big split of the S2, that's pathognomonic for what defect? Atrial septal defect. And is it a primum or a secundum? It's probably a what? Because the primum is going to be very complicated with other sounds and murmurs and things, and other sicknesses and shunts and cyanosis, so it's going to be a different ballgame if you talk about primum defects and what that sounds like, which we're not going to. Okay, so it's delaying the pulmonic valve closure. Now they're not going to ask you to explain what we just explained, but and so instead of just trying to memorize that, like what if you get mixed up, you say, oh, was it a fixed split of the first heart sound, or was it a fixed split of the second heart sound? I can't remember. But if you know why, then you'll get that question right. You just have to think through it for a few seconds. Oh yeah, that extra blood that has to get through. It's taking it longer. The pulmonic valve, like, I can't close yet. I got all this blood, close. Pulmonic valve's delayed because that's on the right side. Remember, the blood went from the left to the right through the hole because the gradient's higher on the left, correct? So the blood goes from the higher flow to the lower flow number. So now you remember that, and you'll get that question right, and you won't have to be sorting out through with it. Okay? All right, so keep looking at that. Eisenmenger syndrome is when you have a shunt long enough that you have permanent pulmonary hypertension. So that's not anything desirable. We want that low pulmonary pressure, because if you get too high a pressure in the pulmonary artery, it can become permanent and cause heart failure and permanent damage that even if you did a transplant, it won't fix the problem, because the pressure will stay high in the pulmonary artery. So if you cut out the heart and put a new one in there, they'll still have pulmonary hypertension, fatigue, shortness of breath, and they won't be better, and they'll still have heart failure. So we don't want Eisenmenger syndrome ever to develop. So that's sort of an end-stage, elevated, right-sided heart pressures from uncorrected shunts. We need a break? Are we dying? We got a lot to go through, so keep the ones break. Okay.
Break.
Okay. So not too long. Let's be back by, let's just like 10 after, okay? Not too long, 'cause we've got a lot to go through.